I can't hear anything. Hello, I can't hear anything.
Ma'am, can you mute
Yes,
yourself,
yes.
please? Kindly mute yourself. Yes, we will be starting in a minute. Thank you. Ladies and gentlemen, friends and colleagues, and hopefully a few little children also. Good morning and welcome to our third webinar, and for the future, perhaps the most important of our entire webinar series in ObeFit, Obesity and Fitness. So this is our 10th webinar. Our topic is childhood obesity management. Now, prior to any webinar, the night before, I usually do a little reading to try and understand what the status of that particular subject is. And I found out last evening that there are more obese children in the world today than there are underweight children. This was not the case in my generation when I was a young child. But as on today, there are more obese children than there are underweight children. One of the leading countries in obesity, with a 28% obesity ratio for children, 28 or some such similar figure, is our own UAE. And when I look back on the research that we have in RAC Hospital, since we manage child health for our emirate, when I look back on those figures, I discover that 67% of our children's parents are overweight. 47% of our children eat fast food almost every day. 35% of our children spend several hours on their electronic mobiles and their TVs. And surprisingly, more than 20% of our children do not participate in any type of physical activity. Now, what is the consequence? The consequence is obesity, and the correlation between obesity and children is that obesity results in adult problems in children. And we are talking in terms of hypertension, diabetes at all, of which, of course, our speaker is the expert. But it's just information that I picked up. And ladies and gentlemen, we have an eminent speaker with us today who will be talking on the subject of childhood obesity. He is the head of department and a senior specialist in pediatrics and a frequent communicator in our various webinars. I recall that in our ObeFit webinar also, Dr. Vishal had spoken on a couple of occasions. And it is indeed a pleasure for us to have him back over here on a subject that is close to his heart, and that is pediatrics and children. Now, Dr. Vishal Mehta, as you can see, completed his MBBS from Belgaum and then went on to obtain his MD in pediatrics from the prestigious PIGMR. That would be the Postgraduate Institute of Medical Science in Chandigarh. He has 19 years of extensive, and if I may say so, varied experience. He was with his Chandigarh alma mater, that is PGIMR, and then he went on to, again, the prestigious Tata Memorial Hospital, where he was associated with pediatric oncology. Then to Leelavati Hospital and Fortis Hospital and the Serum Institute, where he was the Assistant Director of Vaccine Research and Medical Affairs. Truly a broad spectrum, and we are honored to have him with us over here in RAC Hospital. He has a special love and interest, professionally as well as personally, for children, and he is particularly interested in pediatric intensive care. Ladies and gentlemen, I offer to you Dr. Vishal for the next half hour or 40 minutes, who will talk to us about the serious problem of childhood obesity. Dr. Vishal, sir.
Thank you, Professor Kennedy. Thank you for your kind word and introduction. And good morning and welcome you all. Today I'm gonna, let me share the screen. Okay. Good morning, everybody. A warm welcome to you all on this beautiful day. And we are going to today talk about obesity in continuation for the children now. So my talk today, I'm going to focus on how children are different. You know, obesity, we have been listening, we have been talking a lot. Today, let's focus a little bit on how children are different than the rest of the adults, even in a common problem like obesity. So childhood obesity, as we all know, has become a major concern today. It has been increasing in number as well as the proportion of children having this condition, and it has resulted in serious medical conditions due to excessive weight and because of the fat which gets stored into the body due to overweight. Now, if I look into the statistics, let me just show you a few statistics before we go into the obesity disease itself. This is the WHO statistics, wherein we can see that now today, in last 5 decades, the percentage of the number of children having overweight or obesity has increased almost 5 folds, 5 to 10 folds increase in number. This is the WHO, it's a worldwide data, and it is a lot more in developing countries when we compare the same data. Now, you can see the CDC report, which shows the data of the last 3 decades, and it shows that almost the number of children or adolescents with obesity has increased 3 folds more. This is the worldwide statistics, which says that almost 1 out of 3 child is today either overweight or obese. And the projection says that the children or the adolescents aged between 5 to 19 living with obesity in the worldwide, which is around 158 million today, would increase over a period of time. This is a prediction chart, which would increase almost to around 254 million by 2030. Now, this trend is not limited only to the the increase in number. We can also see that the number of children who are getting obese increasing as with the age increases. Today, we see a lot more number of even young kids as low as age of 2 to 5 years being more obese than what they used to be before. And many of these children, especially more if they're obese at teen, will continue to be obese even in the adulthood. The statistics, as Professor Kennedy had mentioned in his introduction, that we are seeing that UAE is one of the countries with highest proportion of childhood obesity. This is the statistical data which we see from the Middle Eastern and North African countries, where UAE is almost among the top 3 countries when we look into the percentage of children in proportion to the population being either obese or overweight. Similar data was also shown in one of the local study which was done in Abu Dhabi, wherein we can find that more than 30% children, either they are obese or overweight. So before this is that is numbers are increasing, but how do we define obesity in children? See, the obesity in children is mainly decided based on the weight and the height. So here we do use BMI as we use in adults, but there are no fixed numbers of BMI. The BMI is calculated for the age and age and sex specific percentile charts. So in this chart, we can see that if the children are in the range of 85 to 95 percentile of their age BMI charts, then they are considered to be overweight. Whereas the children who are more than 95th centile for their age BMI chart are considered to be obese. And anybody who is 120% more than the 95th centile is considered to be extremely obese. Now, BMI charts are available for the children above the age of 2, and they have been available in CDC websites, and we can use them in our routine practice to diagnose obesity. However, we have to remember that young kids may have slightly different body proportion. So BMI may not be a best tool to diagnose obesity in a very young children. So a lot of research now has focused, especially in the young children below the age of 6 years, to use waist circumference or waist for height as a marker of obesity and also as a prediction of insulin resistance. If you look into the chart here, by the age of 6 years, the BMI charts follow the linear pattern. So this linear pattern can be used for the diagnosis of obesity. So when it comes to children who are a little bit older, BMI charts can help us in making a proper diagnosis of obesity. Do we need to do any special test? No, there are no special tests available to diagnose obesity. Usually the tests are only done to evaluate for the secondary causes like any hormonal abnormality, and should be limited only for the children who have associated other problems, like there is decrease in the height velocity or the growth of a child. Now, if we look into the causes of obesity in children, we can see there are multiple hypotheses, multiple reasons which can be described. We can group it into 3 categories. Initially, those are the individual factors, which could be either genetic or ethnicity in your intrauterine environment. Then the environment which we live, the physical activity, the sleep, the parental factors, a lot of those. Then we have some factors which are in our surrounding, like socioeconomic factor, and then we have environmental factors as well. Now, most of the studies have shown that genetics do play a role or a part of some degree in obesity. But if we look at the current increase in the obesity, it has been dramatically and swift. So it cannot be explained just on the basis of genetics. So what is the cause for obesity? It is not just the genetics. It is what we look is more change in our lifestyle, the food habits, what has changed in past 2 to 3 decades. So if I classify the different causes broadly, let's make it simple for our understanding. We can classify the cause of obesity into 2 groups. There are those factors which are non-modifiable factors. These are which are genetic, or these are which are with our birth and others. So they could be intrauterine factors when before you're born. They could be the environmental interactions, genetic factors, as well as ethnicity. But then there are a lot of modifiable factors which are mainly related to our diet and lifestyle. This includes diet like breastfeeding, the energy-dense foods, sweetening beverages, pre-prepared formulas, breakfast, junk food, skipping meals, vitamin D deficiencies, marketing. Again, physical activities, lack of physical activities like sedentary lifestyle, less exercise, more academic engagement than having a physical activities. Gadgets nowadays with a lot of screen times can all result in obesity. Now, in obesity, basically in children, we want to classify obesity into 2 types. The first important group is the primary obesity, or what we call as idiopathic obesity, where you do not have a specific known cause. And then there is a small group of other obesity, which we call it as a secondary obesity. And that is secondary to certain kind of medical condition, mainly either a genetic disorder or a hormonal imbalance or certain neurological illness, or it could be iatrogenic because of medication and other. A detailed medical history, physical examination, or laboratory test can help us to differentiate primary obesity from the secondary obesity. Before I go into details of primary obesity, that which will be the focus of our talk, let me just quickly touch over the secondary obesity. Secondary obesities, as we discussed, the common cause, let me touch some of them. For example, endocrine cause of pediatric obesity. The common hormones which can result in obesity are like growth hormone deficiency, thyroid imbalance, Cushing disease, pseudohypoparathyroidism, and all of this will be associated with decrease in growth velocity or decrease of height. Uh, Central causes like hypothalamic obesity, which is usually caused by insult to the central nervous system, which is because of the damage of hypothalamus, can result in decreased energy expenditure, and they can also result in obesity. Such kind of obesity is important to differentiate from idiopathic because they may not be amendable with the lifestyle modification, which we are going to discuss later. So if I look into quickly over the hormonal effects, let me concentrate on two important hormones, thyroid and growth hormone. Thyroid and growth hormone, when they are excessive in our body, they result in increased growth and increased obesity. Whereas when there is deficiency, it results in decreased growth, and sometimes it may result in weight loss in such babies or failure to thrive. So if I look at the end results in adult height, because of the thyroid issues which might happen during childhood, can result in overall decreased adult height but increased obesity in these children. Similarly, in the growth hormone, when it is less, children, when it is excess, can also result in obesity. The other important hormones which are also associated are androgens and cortisols, which may also play a role in obesity. Now, even though we talk about these endocrine causes, it's less than 5% of children of overall obesity in which the endocrine or the other medical conditions may account as a cause of obesity. Now, it might be very easy to diagnose in our day-to-day practice if we have a regular height and weight checkup of the child and calculate BMI over a period of time. Now, let me show you one of the example that is, I'm sharing with you a graph which is showing the growth chart of a child who developed secondary hypothyroidism at a later age. So we can see the first chart, this is showing the length and the weight of the child, which we can see that at the age of around 8 years started getting flattened. And the similar effect was seen on the weight, which was a little bit on the lower side. But when we compare both of this, we can see that the height was affected more than the weight. And as a result, the BMI had jumped 2 centiles during this period of time. So hypothyroidism can result in secondary obesity. There are certain genetic causes also which can result in obesity. Again, they account for a very small number of children with obesity. However, you should look for it, especially if you have a child who is not gaining height or who is having developmental delay or has an abnormal facies or other features. Several syndromes have been described with the obesity. One of the classic example is Prader-Willi syndrome. This is one of the commonest cause of obesity, which happens because of deletion of perinatally expressed gene on chromosome 15q. 40 to 50% of children, or almost 90% of adults with Prader-Willi syndromes are obese. But the point we will note also that Prader-Willi syndrome is quite rare. It could be 1 in 30,000 live birth. Now, this is the just a picture to share with you of Prader-Willi syndrome, where we can see a child with developmental delay, extreme obesity, with an abnormal facies. These genetic causes may not be limited only to the syndrome. They can be also sometimes monogenetic, wherein certain kind of genes have been explained to result in obesity. Now, two important genes, two important hormones which we discussed here are leptin deficiency. Leptin deficiency can result in extreme obesity. However, majority of the obese children may also have a higher level of leptin. So leptin regulation still remains sketchy, and there is a lot to understand more about this hormone's relationship with the obesity. Several other monogenic obesity syndromes have been identified. Most of them are related to leptin and melanocortin regulation pathways. For example, like melanocortin 4 receptor mutation has also been associated, frequently known cause of monogenic human obesities. Now, this is just to summarize, the list goes too long, but just to summarize, although it accounts for less than 5% of children, but yes, you should actively look for if there are any syndromic features in the child, especially in those kids who have developmental delay and single gene mutations, especially if you have a extreme obesity in early childhood with developmental delay or not gaining enough height. The number of genes which have been associated with obesity keeps increasing day by day. There are too many of them, but accounts for a very small number of people with obesity. So if I have to go a simple approach, I would any child who comes with regular weight checkup and we find him to be on a higher side of the weight, we would elicit a detailed developmental history along with proper diet, family history, and a physical examination. So those children who have onset of obesity at a very early age and are associated with developmental delay or short stature should be suspected of genetic disorders and should be evaluated for those. However, the children who have a normal linear growth, their height is normal for their age, they're normal in development, but are obese, their BMI is more than 85th centile or 95th centile as per the CDC charts, then they are diagnosed to be with primary obesity. And that is usually related to our lifestyle and diet. The third group are those which are endocrine causes. Endocrine causes would be only suspected in children who would have a decrease in linear growth or who might have delay in the bone age. So in such patients, we will suspect endocrine disorders and would evaluate for thyroid and other kind of hormone disorders. So if I try to summarize the different cause of obesity in children, the medical and the genetic factors accounts for less than 5% of total number of children who are obese today. But we do have a lot of other environmental, socio-economic factors. Like, for example, nowadays technology advancement has made our life too easy. Kids are getting lazier, they're moving less. Less physical activities can result as a cause of obesity. High rise in diet changes with rise in the fat intake in the diet. There is lack of physical activities. We don't have an environment which supports the physical activities in the children. There is increased number of fast food centers wherein you have easy access to a lot of fast foods, and children do get easy access and have that food. Many a times we use food just as a comfort eating rather than actually hunger. There is still a lot of lack of understanding about the nutrition of a child, wherein mothers would believe that eating more is more healthy than eating less. There is rise in high sugar diets, including the drinks like Coca-Cola, Pepsis, and other kind of aerated drinks. All this has resulted in obesity. Now, if we look at the vicious cycle which goes on for the childhood obesity, a healthy child, in today's world, he gets easy exposure to a lot of sedentary activities like video games, watching television, playing on mobile. And then there is a high fat food and easy access to those food, and plus a lot of stress by the parents for the studies and lack of physical activities at the school as well as at home, start resulting in child getting a little bit obese. Once he's a little bit obese, he starts inhibiting movement, feels tired, I don't want to move around, and that increases his obesity and he gets moderately obese. Once the child is moderately obese, he feels uncomfortable to do exercise, starts complaining of pain in joints and other places. So he stops his physical activity more and he starts getting severely obese. Once he's severely obese, he start getting other problems like asthma, diabetes, musculoskeletal problems. Exercise goes down. He has psychological problems like depression or low self-esteem. Stop doing those exercises, starts taking more binge eating, and eating problem starts. And that results in an obese adult later on. And obese adult can have a long-term health problems such as cardiovascular disease, pulmonary diseases, diabetes, and they have a higher chance of dying before an average age of other healthy adults. So as we have seen that the most important factor for obesity is our lifestyle and the diet what we have. And lifestyle and diet are the modifiable factors. These are the factors which can be taken care by us. Now, the important factors, as we know, it's nowadays the fast foods and the food habits, the sedentary lifestyle, which is promoted by the technology today. Where you have a lot of video games, the mobile, the television access, where children won't do more physical activity. So to show you briefly that what has dramatically changed in last few decades, why we are here, why we are different, what was different before and what is happening now. Like, let me give a simple example. Most of the children, when we were young, we used to walk to the school. Nowadays, children don't walk to the school anymore. They don't take bicycle. They drive to the school or they take a bus to reach to the school. Most of the children don't walk upstairs now. They have escalators, they have elevators to take them up. Children usually now stay more indoors after school time, as both of the parents might be working. Sometimes there is nobody to supervise them. So they end up being at home and then doing more sedentary activities at home. So when child is at home, it has increased the child's television viewing significantly in last couple of decades. The amount of time children are spending watching screens like mobile, television, playing video game has increased significantly in past few decades, and this has diverted the child from physical sports, physical games with other children. They like to play with themselves, stay at home, play video game rather than go out and play with other children. And all those things has resulted in also decreased physical activity. Even the schools have changed, wherein the physical education classes or extracurricular sports activities have decreased significantly, more so in probably past couple of years after the pandemic of COVID, wherein most of physical activities have been stopped in the school. Now, there has been also food changes which has taken place in last few decades. What has changed in the food? Now we can see fast food centers everywhere in our surrounding. The portion of food which is given in the fast food centers have also doubled. We get a lot of frees, buy a burger, you get a Coke free. So many outlets are now offering larger proportion with almost same cost or lesser cost. These fast food centers are more aggressive in marketing. They have a lot of marketing about the fast food centers, junk foods, and the video games. The children. In fact, one of the studies has shown that children have food preferences based mainly, or they get influenced mainly on the commercials, what they have watched in last 30 seconds. They watch something on a TV and they want the same thing next day. So this aggressive fast food commercial marketing has also influenced our children, and children are moving more toward fast food. Almost, if in today's world we see 1/3 of the children, or probably more than half of the children, eat fast food almost every day. And with the now, even if you go to the school, they have vending machines, or they serve the fast food to the children, which contains of snacks and a lot of empty calories. So what are the risk factors which can result in obesities? Now, there are several risk factors that are associated with children being obese. If we look at one of the research studies in obese children, that children who are obese are more frequently diagnosed with diabetes mellitus, or they show early signs of insulin resistance syndrome, and also have higher incidence of cardiovascular disease. It is estimated that almost 50% of children who are obese or overweight will continue to be obese even in their adulthood. This will further increase the health risk and the risk of premature death in this population. Now, to summarize, what complications obesity can cause, it is not much different from adults, but I will stress on 3 important complications, what can happen. The most important complication is for the cardiovascular system, where you can develop early hypertensions, endothelial dysfunction, dyslipidemia, and later on resulting in ischemic heart disease in adulthood. The second important group of problems, what we see, are pulmonary problem. Young kids, obese, priming with problem of sleep apnea, increased incidence of asthma or exercise intolerance, which again results in decreased physical activities and increases the obesity. So it's like a repeating vicious cycle which keeps going on. And the third important problem, what we see complication because of obesity in children are mental health problems, poor self-esteem, depression, eating disorders, or neurological illness like pseudotumor cerebri, all can result because of obesities. To mention other causes also, like musculoskeletal problems, children who have obese can develop bored legs like Blount's disease, or a slip capital femoral epiphysis, or a flat foot. And they can also have higher incidence of endocrine disease, mainly type 2 diabetes. It has been shown that type 2 diabetes is almost seen in a majority of the children who are obese. It can also result in adolescent with precocious puberty, or polycystic ovarian diseases in girls, or hypogonadism in boys. So the list goes on. There are a lot of multi-system complication which results because of childhood obesity. Now, this is just to summarize those what we discussed, mainly to concentrate that type 2 diabetes, cardiovascular disease, liver disease, reproductive diseases, heart diseases, and also not to forget the mental health problems, especially mood disorders, can result because of overweight or obesity in the children. Some of the unique problems which we don't see in a healthy child, which we can see in the obese child. For example, obstructive sleep apnea. It is very common in obese children. And this obstructive sleep apnea can result in poor quality of sleep. So these children are always tired in the daytime. They do not perform as well they are supposed to. And that again aggravates the obesity in these children. Problems like gastroesophageal reflux disease, or impaired balance, or the joint problems. Also, social or mental problems like low self-esteem, depression, social isolation, or teasings can all be unique in pediatric age group. Asthma has been shown to be strongly related to obesity, although we do not still understand the exact link or the mechanism which is causing increase in asthma and obesity in children. However, the data has shown that almost 25 million of new asthma cases who are diagnosed, 25% of the new asthma cases which are diagnosed are found to be obese. So out of every 1 out of 4 child who is newly diagnosed with asthma, one of them is already obese. And also it is almost higher risk for asthma attacks in obese children in comparison to the children who have asthma but have a normal weight. So if you are obese, you have to almost 1 out of 3 child will have more risk of developing severe asthma attacks. Now, there are a lot of theories which have been explained. One of them is probably mechanical impediment, wherein there is a fat infiltration in the thoracic and abdominal cavities, which results in increased abdominal pressure and then decreased tidal volume or the airway calibers due to inflammations. So again, no exact cause known today, but what we know for sure is if you are obese, you are more likely to get asthma. And if you are obese, and you have asthma, then you are more likely to have higher asthma attack rate. So when we talk of obesity, it is not just diagnosing obesity or managing. We have to also look for the comorbid conditions. There are problems which can come along with the obesities. So these children, we don't do a routine lab testing for the children to diagnose obesity. However, those children who are already obese may need a screening for the complication or comorbidities of the obesity. The most concerning risk factors are with the cardiovascular complications, which can result in early onset of heart disease. Like we need to look for hyperlipidemia or impaired fasting glucose that predicts in future the risk of type 2 diabetes or cardiovascular diseases for these children. So all the children, what we recommend is children who have body weight or BMI, which is more than 85th centile. So they are either overweight or they're obese and their age is more than 6 years, should have some baseline investigations to look for comorbid problems. For example, fasting lipid profile, fasting glucose, or a liver function test. If there is an associated physical finding, like a child has acanthosis, hyperpigmented skin on the neck, we call it as acanthosis, wherein they can have an insulin resistance. So impaired fasting glucose has to be done for them. If you have a family history of diabetes or mother had a gestational diabetes, it warrants further testing such as HbA1c or 2-hour glucose tolerance test and a fasting insulin level. This is just to know how we diagnose those comorbid conditions in the children. I'm not going to go into details of this clinical things, but just to briefly mention, if a child who is more than 6 years and a BMI is more than 85%, and you do some baseline investigation, you're looking for diabetes, you're looking for hyperlipidemia, you're looking for other comorbid conditions to predict the future risk of diabetes or risk of cardiovascular disease. They can be diagnosed as pre-diabetic if their fasting glucose is more than 100, or they can be diagnosed as diabetic if their fasting sugar is more than 126 milligram. Now, the ranges of this glucose may change for different guidelines, but this is just a rough guide to make you understand how do we diagnose in children. Dyslipidemias, if the fasting lipid level, the triglyceride is more than 110, and if LDL levels are more than 110, or total cholesterol levels which are more than 180 are considered to be dyslipidemia in children, or a blood pressure which is more than 90th centile. In adolescent, it could be more than 130 by 80 is considered to be hypertension. So are there any special tests we need to do in obesity to look for other comorbid conditions? Certain special groups might need additional testing. For example, if you have an adolescent girl who comes with hyperpigmented skin of the neck and has a problem with like acne, hirsutism, excessive hair on the face, has to be screened for polycystic ovarian disease. Pediatric patients should, especially if they are extremely obese, should also be screened for obstructive sleep apnea diseases. And children with hypertension should also be screened for other cardiovascular complication. This is just to show you briefly how the polycystic ovarian disease child would look. And these children might come with several problems, including obesity. We can see child having excessive hair growth on the face, acne, and then when the scan is done, we can see this multiple cysts in the ovaries. Again, this is just to make a proper diagnosis so that if managed in time, we can avoid obesities and many other complications associated with the obesities in these children. So when we do a physical examination of a child, we are focusing mainly on the body proportion of a child. Look for dysmorphic features so that you know if you have to look for any genetic or syndromic causes. Look for the hyperpigmented skin on the neck, that is acanthosis nigricans, to decide if you want to evaluate for insulin resistance in the child. If female patient is present with acne, hair growth, or menstrual irregularity, then you would look for polycystic ovarian disease. What we need to always check during our regular well baby clinic checkups are weight, height, calculate BMI based on that, and very young children, they should have their waist circumference also recorded at each visit. Sometimes the trend matters rather than the point findings. That will help. Now, can each group is same when we are managing the obesity? No. Children are unique. They are growing. With the growth, they have different problems and different physiology. So when it comes to children who are below 5 years old, when they are a very fast growing group and they are obese, my focus would be to identify the patients at future risk, focus on prevention, screening, and counseling. So we want to identify even before they get obese and monitor them and prevent the obesity in these children. Children who are already 6 to 10 years age, the focus would be to identify those who are already obese and look for secondary factors like early puberty. And the same thing like screening, counseling, diagnosis, and then treatment has to be followed. Children who are 10 to 15 years old, these children are near their puberty almost. So here the screening of the diagnosis has to be made for obesity and look for other metabolic syndromes like polycystic ovarian disease, thyroid problems, or if diabetes to be managed. And older than 15 years old children needs treatment of obesities, prevention of secondary complications, or treat the comorbid conditions if they are present any. Certain medications can also result in obesities. This is more so in adolescent age group, wherein we can see that, especially if you have a medical condition where child has been on glucocorticoid treatment, it can be associated with excessive weight gain, with visceral fat accumulation, that again results in risk of cardiovascular disease and diabetes. Just few drugs to mention. For example, a child with epilepsy, if he's on valproate, or an adolescent girl who is on OCBs like oral contraceptives, or a child who is receiving ciprofloxacin for improved appetite. All these drugs are known to cause obesities in the children. Treatment with certain kind of antipsychotic drugs like risperidone or abilify can also result in obesity or increase in the body weight of the patients. So what we look here in obesity is that it is not one factor, it is the multiple factors which play together a role to result in obesity. So there's a lot of evidence to show that it's a combination factor. It is not just one particular factor always in most of the people. So the most common cause would be that you have a genetic predisposition, and then there are the environmental factors getting involved, and that results in pediatric obesities. There are studies where, for example, there are studies which have shown that the babies who are born small for gestational age, that could have, it can have more impaired glucose tolerance during, like for example, mother has gestational diabetes, she has impaired glucose tolerance. So there is increase in insulin resistance in her. So this same thing happens in the baby. So these babies who are born small because of the maternal diabetes, later on when they are born, they have a higher insulin level in their body, and the composition and the size of baby might later on, be more than other kids. So this can result in obesity, early puberty, and later on metabolic syndromes. So what is the treatment for obesity in children? Well, the best treatment for obesity is, as we all know, is prevention. You prevent it, and that's the best treatment. Several studies have been focusing on the impact of, improving nutrition or decreasing the weight gain, even during as early as, preconception, during pregnancy, or the impact of glucose tolerance, which will result in insulin sensitivity in the infant and determine their future risk of obesity. Healthy nutrition starts right from infancy and will continue throughout your life. The main treatment still remains to be diet and exercise. So what are the goal of our treatment? When you treat obesity, what are we focusing on? The goal of treatment is to increase the energy expenditure. So we want to spend more energy and decrease the intake of the calories. The intake should be decreased while the expenditure should be increased in proportion to the growth of the child. So the long-term objective of the treatment of child with obesity would be two important things. One, to reduce the BMI, and second, it would be to reduce or prevent or reverse the short-term or long-term comorbidities or complications arising out of obesity. So before we talk of what intervention we do, there is very important that we understand the significance of healthy weight and dieting. Dieting is always considered to be as a treatment in many of the population, but that's not true. So let's focus and see what is healthy thing, because in last couple of decades we have seen that obesity and association of eating disorders like anorexia, bulimia, in past couple of years there have been a lot of associations seen with this increase in obesity. In fact, it is even seen in children as young as 5 years. They exhibit purposeful food avoidance, or they try to lose weight by not eating food, or they are conscious about their body looks, and they're dissatisfied with their appearance. So we have to keep this very important, that rather than treating the weight, let's understand what is healthy weight concept. So it is very important that emphasis is on increasing the physical activity and eating right type of food rather than restricting any kind of food. Children should eat food, but a right type, and concentrate and encourage them to have a physical activities. Bring in a conducive environment wherein they can do more physical activity. There should never be a stigma attached to being overweight or the appearance of a child. So we have to maintain the self-esteem. It's very important and very integral part of our management. Child should be encouraged to make choices, give him a choice, healthy choices, right from very young age, as soon as they start having food. And the parents also should serve as a role model. The children learn what they watch, they learn what they see in their surrounding. So we parents have to be a role model for the child and always give them a choice rather than force feeding. It should never be done. So stop using food as a reward. You do this, I will give you this. No, the food should never be used as a reward, or it should not be restricted because you want to punish him. And child should never be forced to feed. So we give them choice, we make them understand the healthy choices, what is the food good. So if I summarize this, you can see that when you how to end childhood obesity, I would follow this 6 simple steps. First is healthy food. Second would be increase the physical activities in the child. Third is starts right from preconception, right from pregnancy time. Take care of gestational diabetes. Mother should be on a healthy diet. We start counseling or educating the mother right from pregnancy about the right nutrition for the child and the parenting style or diet of the family. Next would be, as soon as the child grows up, then early childhood diet and physical activities has to be stressed. In the school also, we need to continue with health, nutrition, and physical activities has to be done. And then later on, if there is overweight, then we need to manage that overweight also. So what are the roles of lifestyle and diet? So one of the very interesting studies, where the motion sensors were attached to the babies, and what they found that the children who spend less time in moderate vigorous activities were at a higher risk of developing obesity during childhood and adolescence. So there is a positive correlation also between the children who are watching more TV and being overweight. So children who spend more than 7-8 hours watching television might end up being more obese than their counterpart kids. Eating patterns in children and adolescents have changed, as we discussed in past few decades, wherein there have been more consumption of fast foods. Dietary factors like can place the child, wherein obesity includes high fat intake, high calorie intake. Obese children tend to skip the breakfast. They don't have breakfast at all, but what they have is a very large amount of food at dinner later on. So even when you say you take less meal or you skip the meal, you end up having more later on. So this kind of modifications won't help us. The only thing which has been shown that, to have a result in weight loss or which achieves weight loss, was concluded that the only treatment which works is comprehensive, intensive, behavioral intensive programs, which should be more than 26 contact hours. So the program wherein, it's organized for behavioral modifications, increasing physical activity, are the only one which are proven to be helpful in weight loss. Successful programs will include the individual sessions for the parents, for the child, the combined or the together sessions for the parents and the child, and then along with a group like with other parents and the child also. So what this modification program should include, 4 important things. The first important stress should be the diet. Diet should be not restricted, but it should be a right choice. So it should include the information, demonstration of healthy eating habits, how to prepare the food, and habit of reading the food labels when you buy the food. The program should also encourage them to be more physically active, demonstrate that physical exercise during supervised activities and the sessions. And we should also educate them during the program about reduction in the screen time. Usually such kind of programs will include a medical care provider, nutritionist, the exercise specialist, and social workers, so that all the things are taken care. Now, if you look at the dietary consideration, mild calorie restrictions can be offered to some children when they are obese. And especially for those children who are motivated and their families are motivated, and this is encouraged to change the long-standing eating habits rather than a short-term crash dieting. So a mild restriction of certain kind of unhealthy excess food items, like, for example, excessive snacking or a junk food or a juices, excessive juices, or a pop can be reduced in the children. There is no specific micronutrient like, just stop the fat and you're going to get weight reduction. No, it has not shown to be very effective. So this still remains controversial, that if we can eliminate one particular macronutrient and treat the obesity. Like for example, low fat and low carb diet, extreme diets don't work. Small amount of mild restrictions might work and bring in long-term modification feeding. However, extreme diets just end up resulting in excessive consumption later. So they may have counterproductive effects, So I would say we would focus on reducing some specific group of nutrients, like for example, sugars, excessive processed fat, calorie, small amount of calorie restrictions might also help us to reach the specific goals. But again, no crash dieting is recommended for children. Stress on increasing physical activities. Children should be encouraged to participate in sports, physical active at a very young age, so that it becomes a habit for them. Activities can be done also in families. Your family activities can help not only for the weight reduction, it can also help us to facilitate bonding as a family unit and also improve the health of overall family members. For example, like, there are a lot of family activities. I'm just going to give some example, like, playing catch with the small babies, or a family soccer or a basketball game, or family hiking can be done. Maybe you take a gym membership for a whole family and you be there, or you go for a swimming or a skating there. Children activities like dancing, clapping, singing can be started from a very early age. Enroll them in any organized such activity program, so it becomes more interesting for the child, and they learn and they get motivated to do it more. Parents have to be role model. We cannot be sedentary and expect childs to be active. So we are going to be a role model for our kids. So we need to change our physical activity levels, so children also will follow our examples. Um, the certain other things which are very important is we have to limit the screen time. Excessive watching of television, games can result in sedentary lifestyle, and the vicious cycle of obesity starts from there. On contrary, I would suggest that children should be encouraged to read books from a very young age. So that gives them, alternate um, option of engaging them. And also it can be combined with, like, family hikings, and your destination may be a library, or you can have a library at home, rather than being on gadgets for a very long time. uh, I'm going to just talk a little bit right now on the eating disorders which are associated with the obesity. We have seen that in past few decades, there has been a lot of eating disorders being associated with obesity. Like, for example, children are likely to engage in disorganized eating. They skip meals, they avoid food, they starve, and then they end up binge eating,
Yes.
as well as it can result in self-induced vomiting and use of laxatives and other. Almost 36% of teenagers seeking treatment in ED. This is by the American Academy of Pediatrics 2016 publication. They found that almost 36% of teenagers who visited emergency department were previously overweight, or their BMI was more than 85%. So what are the recommendations? What we should discourage dieting. What should we encourage is right choice of the food. Skipping of the meals should be discouraged. Use of diet pills should not be encouraged. Instead of that, we should encourage and support the implementation of healthy eating, increased behavior, physical activities, behavioral change that can be maintained for a ongoing basis rather than a short-term focus. The focus has to be on the healthy living and healthy food habit rather than only on the weight. Promote positive body image among the adolescent. Do not encourage body dissatisfaction in the children. For the meals, we should also frequently, we should encourage family meals. We don't have family meals nowadays. Family meals should be encouraged, because it has been shown that the children who participates or who have sit with the family for the food are less likely to develop eating disorders. Families should talk more about healthy food habit, and not to talk much about the weight of a child, rather than talk about healthy eating and being active and how to stay healthy. We should, especially in adolescent kids, if they are obese, they may have other mental health problems. So you should always inquire or spend some time talking to them to understand if they are being bullied because of being overweight, or there is some mistreatment at the home. Careful examination of weight loss in adolescent is also important to ensure that they do not develop any kind of medical complication because of crash dieting or semi-starvation. Mental health problems, just to touch briefly on the mental health problem, there are a lot of mental health problems, especially this is mainly for the adolescent age group, wherein there has been link of pediatric obesity and the depression. I will give you a two good example. There was a study wherein 9,000 youth who were already depressed or had some mood problems were prospectively followed. We looked at them over a period of 1 year, what happened to them. And we found that significant number of these kids later on turned to be an obese child. So you have a depression or other mental health problem not addressed, that can result in obesity. Similarly, the other study wherein we look, other way around, rather than looking mental problem and then resulting in obese, and this was looked in the children who were already obese, especially it was a study which was done in New York, wherein the female age up till 19 with obesity were seen, and they found that there was significant increase in the number of mental health problems in them, like depression, anxiety, and other kind of mental health problem. So the children, when they are obese, or adolescents especially when they are obese, we should always look for mental health problem. Look for if there is depression, anxiety as a result of any other, it may be a social or a family issues, it may be a family conflict, or it may be bullying at the home or a school, and child might use food as a therapeutic agent just to cope up with the stress at that time. So treatment of depression is also equally important when we talk about management of pediatric obesity. Drugs or the medicines, this is the common question I always get. Somebody asks me, doctor, can we give some medicines to reduce the weight? Well, I tell them, everybody, one thing: there is no magic weight losing pill, at least not as of today. So the pharmacotherapy or the drugs or the medicines used in obesity is controversial. It's controversial, especially in the pediatric. We do not have enough studies to prove they are safe options. Till now, it can be seen even by the fact that as of now, there is only one medication which exists as a treatment of pediatric obesity, and that too only for children above 12 years age, that is Orlistat. Again, the results have been conflicting, and we have to always be careful about the side effects which are associated with the pharmacotherapies. The other drug which is used sometimes is not to treat as obesity, but to manage the comorbidities or complications, that is the metabolic syndrome which comes because of obesity in adolescents, especially with the glucose intolerance or acanthosis, is metformin, which can give a favorable metabolic outcome. But again, it doesn't help in reducing the weight. It only helps in treating the comorbid conditions. Just to touch brief on bariatric surgery in children, nowadays weight loss surgery, it's a popular, everybody knows about it, everybody talks about it, and even I get sometimes, parents inquiring with me whether they can do a surgery to reduce the weight. Well, no, long-term success of lifestyle intervention or pharmacotherapy, especially in children who are extremely obese, can sometimes be a little bit disappointing or disheartening because the results are not immediate in such cases. So some of these children, very rarely, I would say, may need more aggressive approach like bariatric surgery. But this is only in a very selected subjects, especially with those who have a kind of comorbid or other problems, then only it is done. Surgical approaches are same as they are done in adults, like sleeve gastrectomy or bypass procedures or banding. But again, it has its own selected subjects to be done. Complications are there. So just to conclude it quickly, what we take home message I would like to give today is that pediatric obesity is very real. It is rapidly emerging risk to the general population and will affect the health and wealth and well-being of our future generation children. Obesity is multifactorial. We do not know much exactly on the origin. There are a lot of hypotheses, a lot of theories, but there is still a lot of unknown region in origin or as well as the treatment of obesity. So the best treatment at present would be prevention, and we must focus our treatment in that direction. Diet and lifestyle changes are the key important things to take care in treatment of obesity. Thank you.
Thank you, Dr. Vishal. Thank you so much. That was comprehensive and all-encompassing. You probably said everything that there is to know about childhood obesity. Thank you so much for the time you spent with us. Some of the highlights of the things you mentioned is that almost 1 in 3 children are obese. Young children frequently become obese adults. The gene factor or the hormone factor is less than 5%. And you did mention that the important factors in managing childhood obesity should be the lifestyle factors. Avoid too much of automation in terms of transport to school, etc., where you can walk, use the lift or steps instead of the elevator. You emphasized a great deal about TV time and mobile time. Thank you so much for that. But we will need to ask you a specific question in that area. You spoke about food portion sizes that have been increased by fast food centers. You spoke about the aggressive marketing. You said that food should never be used as a punishment nor as a reward. That is interesting. You advocated family activity, which would be good not only for the child, but also for the parent. And you suggested that children who are obese should have mild calorie restriction. You emphasized the word mild, but you did say that they should have moderate exercise activity also. You ended by saying that prevention is perhaps the best treatment. Dr. Vishal, a few questions that have cropped up, and I will mention a few of them over here. Just a few questions, if you can clarify these questions. Now, one individual has asked, eating junk food results in obesity, as mentioned by you. Is there any limit that you would like to specify on eating of junk food in terms of meals or whatever? So what is the limit for children in terms of eating junk food? Do you have any such limit, Dr. Vishal?
No, there is no specific limit as such. You know, if you ask me, can I eat once in a week or once in 2 weeks? No, there is no number of junk food. See, the emphasis here is not on how much amount of junk food you're having. The emphasis is your eating habit, you know, the habit which continues. So the junk food has to be totally avoided in children. Once you stop having junk food, children are going to opt for a healthy food habit. And that will also happen when we as a family or a parents are going to play a role. Okay, once a while, I would say, again, I don't give you the number, but it may be once a while, everybody wants to have a change, want to have a fun, you can have those changes. But using it as a routine food habit, you know, where you see one of the slides I showed you, that almost more than 25% of children have this junk food or high calorie food almost on everyday basis. So that has to stop. What has to stop is not just junk food, the eating habit. You know, the eating habit has to change to healthy food habit. Increase the amount of fruit and vegetable intake. Decrease the amount of processed food, especially with those with high sugary or high fat intake foods.
Okay, another question, Dr. Vishal. You did speak about TV time and video games and other such distractions for children. Again, a concerned parent says, do you have a limitation in terms of time?
Yes, there are standard guidelines, you know, wherein they have given their recommendation what children should be doing. The children younger than 12 years age now, if I go by American Academy of Pediatrics recommendation, it recommends a screen time of not more than 60 minutes per day. So the child's exposure to the screen, that includes mobile, TV, or video games, non-education purpose, should be restricted to 60 minutes. I know it may not be always possible now, especially post-COVID time, where children are distance learning, and they have a lot of school activities which has to be done on the screen. It will be difficult. But then again, this is in their regular school timing. But the post-school timing, the screen or video game or other activities should be restricted to 1 hour. This is the guideline. Again, my advice to the parent would be very simple: lesser it is, better it is. As much less, as much possible. If you keep number as 2 hours, it's going to be 4. What you're going to do? Children, keep it 1 hour or even less than 1 hour, so that you end up having at least something less than what they had before. And once they are not on the screen, it is going to give them ample opportunity, to interact with other children, go out and look for play. So if I have a video game in my hand, I don't want to go out and play. But when I don't have video game, what I'm going to do? I'm going to find ways to keep myself engaged. And that would be by looking to do some physical sports activity rather than playing with the sedentary fun games or other things.
In one of your slides, Dr. Vishal, and it has been asked by a parent, in one of your slides, you have mentioned that usually, or it has been found that children who eat a heavy dinner and avoid breakfast, well, you actually said that in obese children, it has been found that they usually eat a heavy dinner and avoid breakfast. A little advice on that area is what the parent is asking for.
What I was trying to stress in that slide was that this was finding what they saw in adolescent obese kids, that, when they were trying to do crash dieting or food avoiding, they skipped the breakfast, they did not have a lot of food in the daytime, and then they ended up having more heavy dinner. So they did not achieve their goal. So the emphasis here is not to skip the meals, not to stop eating. The emphasis is to make healthy food choices. So have your breakfast, have your lunch, have your dinner. It is not to decrease the quantity, but have a right proportion and the right quality of food. There is no need to skip any meals. Children are in growing age. They need nutrients for their growth and development. They need micro and macronutrients. I couldn't go through the nutritional side because it's a separate talk on itself, but they need that for their growth. But there is something which we can avoid, that is unnecessary calories. We don't want to have a big one meal. Rather than that, we need to focus on small frequent meals in the child, and with variety, a balanced diet with vegetable, with fruits, some proportion of fats, some proportion of protein. I would like to stress one thing very clearly to the parents, that see, children, if you look at the children's nutrient requirement, children need a little more fat than what adults need. And that is because of their mental development. Nervous system needs fat. But what kind of fat we are giving, that is important. So if you use the fats like omega-3, omega-6 rich foods, they are going to be healthy for the child, for the mental development, and avoid other kind of, unsaturated fats. For example, like butter or a ghee or margarine, those kind of fat items has to be avoided in children. So they need fat, but it is not important to stop the fat, but give right variety of fat for the child.
One or two questions have quickly come up on the screen as I see it. And one question is, how much sugar should a child have? According to you, what would be an acceptable limit on sugar?
You mean to say sucrose? Are they asking?
I mean sucrose, yes.
Yeah, maybe specifically to the sugars as such. See, excessive consumption, because when we talk about sugar, we are not talking about only one particular sugar. We are talking about the overall calorie, So there are food which are in high sugar values, which have very high calories. So those kind of foods should be decreased in our diet plan. Adding 1 spoon of sugar to a milk or other food for a child who's more than 1 year age may not be a problem. But having a lot of chocolates or those kind of high sugary food, like for example nowadays aerated drinks, Pepsi, Coca-Cola, they have a lot of undesired or non-nutritional calories, what we call as. So it gives no nutritional benefits, but puts on a lot of calories for the child. So that kind of calories have to be avoided in the children. Your recipe, if I put a simple advice to the parents, just to make it simple and understandable for them, is if there is any sugar which you use it as a recipe for your regular food habit, you can use it. Adding extra amount of sugar or giving food which is only made up of sugar too much is not recommended for the children.
Okay, Doc. One question which I feel is a multidisciplinary question, which has a little bit of a psychological impact to the question, and that is, what does a parent do if the parent is following a healthy diet and an active life in exercise and sports, but the child neglects sports and eats fast foods without informing the parents, sneaks out and eats these fast foods? Do you have any advice in your experience that can help this particular parent, Dr. Vishal? I'm sorry for asking you a difficult question, but unfortunately,
but this is the common thing which you would hear and see every day. Now, first thing is, see, we have to stop showing the child that he is wrong and I'm right? So that is not going to have a positive impact on the child. So rather than discussing that you are being unhealthy, let's discuss how to be healthy to the child. So first point is, don't try to show him down by saying that I'm healthy and you're unhealthy. So that is first important thing. We have, if the father is following a good healthy habit, and this one of the few slides which I mentioned, you might have seen those family activities, wherein we do it as a group. So family eating time, we all sit together and we have a food at one table. So we're going to have similar kind of food. That's going to have a positive impact on the child. This child is going to sit with you, watch you every day. You're not going to talk about his food. You're not going to talk about how bad he is. You're going to talk only about how healthy and what good food we are going to have today and what activities we are going to do today. So that is going to help us, family activities. Instead of telling I'm running, you're not running, why don't we go for a family, probably today we will go for a family picnic, and let's play football together. And that will improve, that's how you have to improve. We cannot expect child by only telling to do. Or if I'm in this father's place, I would say enroll him in any good physical activity program. Like for example, he likes to play badminton or football, put him in a professional learning course. So that will make him interesting. It will increase his physical activity, and when he learns, he performs better. And when you do better, you want to do it more. So that is going to motivate you. When I go first day, I don't do well, so I don't want to go back again. But when you go in this kind of program where you're motivated, where you learn the things, and then it becomes interesting because you can do better. So I would say 3 advice for this father. Family meals, so sit together and have a food. Second is, try to find some time for family activities where you can plan for some physical activities as a group in the family. We have marathon, we can go for a marathon together, the whole family. And it may be interesting for a child to run along with his friends or run along with his family and watch other families coming together. I would say is try to enroll him in any good program. So he loves the activity, what he's learning. You may choose. There are a lot of activities. I'm not going to stress to this father that you need to always give choice to the children. I'm sure he's talking about an adolescent child, a child who is probably more than 8-9 years old, where he can make independent decision. So he doesn't want to listen to the father and he wants to do what he likes. So here, the best way to promote or to help him would be to get him something he loves or it's interesting for him to do. And when it is professional learning, kids love it. It works, We have to try this. These 3 things, I'm sure if they try over a period of time, it's going to help the child.
Oh, well done. Well done. That was a great answer, Doc. Not only are you obviously a good doctor, but I am sure your children will benefit by you being a great parent. That was great advice. That was great advice. Thank you so much. Friends, we've run out of time. I noticed that there are a few questions over there that are not specifically children related. For example, can we replace sugar with jaggery? I will take the liberty of saying, yes, you could. Jaggery also contains fiber. It is not just pure sucrose, so you can go ahead and do that. The rest of those questions we will answer by email in due course. Friends, I'm wrapping up by thanking Dr. Vishal. And in closing, I would like to talk to the parents that Dr. Vishal has obviously directed his talk to. And he says that there are so many things that you can do. Not too many children have a medical related obesity problem. Those ranges are in 5 or 10%. But the larger percentile of children with obesity related problems can be solved by lifestyle, is what he says. And what I particularly liked is, I've written it somewhere, what I particularly liked was his statement that the parent and child should play together, child and parent sessions. So Dr. Vishal has killed, no, wrong word to use in a medical conference. Dr. Vishal has solved two problems: the problem of obesity in children and also the problem of obesity in adults. Remember that the parent has an equal responsibility to play with the child in order that both the parent and the child loses weight. And one last bit of advice on a somber note. Dr. Vishal mentioned that obese children tend to have adult problems. In our generation, we didn't hear about hypertension, diabetes, depression, anxiety, low self-esteem, social isolation, asthma, and things like this. They didn't seem to exist in children in our days. In our days, children got a cough and cold and probably bruised their knee. But now it is our parental responsibility to take care of our children in terms of obesity in order to avoid diabetes, fractured bones, depression, cardiac ailments, low self-esteem at all. And we have Dr. Vishal to thank for giving us this advice. On my behalf, Dr. Vishal, on behalf of the institution that is RAC Hospital, on behalf of all your listeners, thank you so much. And thank you, participants, for participating. Thank you to my team sitting right here on a holiday and hosting this. Thank you so much. Good day, and we will see you again next week. And thank you so much, Dr. Vishal. I am going out now to play with my grandchildren. Thank you so much. Goodbye, sir.